want to see the patient, that's fine. It's just that.
Sorry.
Sorting out.
Good afternoon. Welcome to Grand Rounds today. Please remember to sign the attendance record at the back of the auditorium, and also please remember to fill out the program evaluation. And the CME committee is always anxious to hear your thoughts in regards to future topics or future speakers. Today, it's my pleasure to introduce Dr. Nima Golchin. Dr. Golchin is actually an Ames native. He attended medical school at the University of Iowa and then did his residency in radiology and fellowship in interventional radiology at the University of South Carolina. And he kindly has accepted our invitation today to provide us with an overview of interventional radiology and some of the new procedures that will be available at Maryville Medical Center. And please join me in welcoming Dr. Golchin.
Hi, everybody. So I was given the responsibility to give everybody here a lecture on interventional radiology in about an hour. So we'll see how that goes. I'm going to try and summarize a lot of topics into a very short period of time. So if I talk quickly, it's only to get things done and try and cover a wide variety of topics. But if you have any questions, please don't hesitate to ask. I love answering questions. I love to talk, if you'll notice, or if you stop and talk to me. I have no disclosures, except I have a lot of student loans. That's about it. Objectives, basic summary here is we're going to summarize interventional radiology procedures, basic ones, when to consult interventional radiology, and talk about some literature supporting or against some procedures we can perform. So what is IR, or interventional radiology? It's basically a minimally invasive specialty that uses image guidance to perform, diagnose, treat, or even cure certain diseases. We use all the imaging modalities for diagnosis, and I predominantly use CT, ultrasound, and fluoroscopy to treat or cure disease. The big thing I want to mention about IR is that we're kind of a problem-solving specialty. Kind of the way we thought about ourselves is, well, what do we do about this patient? I don't know. Let's call IR, see if they can do something, and sometimes we can help. A lot of times we can help, and by doing so, we can minimize hospitalization, reduce costs, reduce complications, and we really do work with pretty much almost every specialty in the hospital. Maybe the dermatologists never see us, but that's kind of the lack of overlap in terms of skin and not skin. So when is IR available? That's a great question. Always. Except when I'm not in town. But even when I'm not in town, you can always call me or email me. I may be on the beach, here after, again, I have to pay off my student loans. But you can always call me, email me. I'm always available to answer questions. I like to get calls. I like to talk. So here's a short list of IR procedures. It's an abbreviated list. Some of these procedures on here, the ones that I've highlighted in red, are probably already being done here in the hospital or in this area by other specialists, and that's great. But there are certain ways I can potentially augment or improve some of those procedures or maybe assist with some of these procedures as well. Again, this is a very short list. The things we can do are very long, and there's just no way to talk about all of them in about an hour. So how do you consult interventional radiology? It should be easy now. I know in the beginning there were some difficulties, but if you just call radiology, the number there, and just ask, that will get to me. There should be an Epic order in as well. You should be able to put in both an ambulatory referral or an inpatient consult. If either of those are placed, we'll see it. I'll see the patient. I'll get them on the schedule. I'll actually even take it from there in terms of getting them set up to have the procedure done. All you just have to do is put it in and maybe give us a call to make sure that we see it quickly. Things that are helpful, any basic information you would give any specialist that you consult is always helpful. All the basic things right there. The one thing I want to point your attention to is that I generally use moderate sedation for everything I do if I can. That's just fentanyl and Versed, so the patient has to be NPO. But the other thing that's important too is think about, can this patient lay flat on the table for about an hour, plus or minus time to do the procedure. If they can't, that's useful to know if I need to call anesthesia to get the procedure scheduled so the patient can experience the procedure more comfortably. Again, one quick thing I also do want to talk about before we get into the procedures is bleeding risk. We stratify in interventional radiology bleeding risk as low, moderate, or high. The high-risk procedures are the ones that we start to worry about, whatever antiplatelet, anticoagulant the patient is on. Those are usually arterial procedures or procedures that I do in the liver or kidney, or maybe even the spleen. The ones I circled here, the aspirins, A baby aspirin does not matter. If the patient is on a baby aspirin, you don't need to stop their baby aspirin for anything. That's completely fine. It does not need to delay their care. They can come to me right away. I'll do whatever procedure they need. The higher dose aspirins, maybe we start to think about taking a couple days off so their platelets can replete. Plavix is also in that category as well. The anticoagulants, warfarin's the big one that we used to traditionally see. Now we're now on those more novel DOACs. The heparins, though, again, same point. It should not stop the procedure. Usually we can just hold it the day of or the night before, and it's fine to do whatever procedure they will need. Those are the newer anticoagulants. Those usually take about 2 or 3 days to wear off before we can do the procedure. So things to keep in mind. Okay, on to the procedures. Probably the most bread and butter thing we do in interventional radiology is vascular access. Things like PICCs, ports, catheters, patients with difficult vascular access. We really excel at doing those kinds of procedures. So things that we like to know: what is it for? Why do they need this? How long do they need it? Do they have an infection? Because if they have an ongoing infection, I should not place an indwelling catheter with a cuff or a port in them, because that will become infected and they experience bad complications and we don't get reimbursed for that hospitalization. So it's something we try and avoid. Also, if they're just a difficult venous access patient, if I'm going to have to do something more novel to get into a vessel, that's helpful to know in advance. Otherwise, I kind of get mad at myself and I stumble through the procedure. Or if they have evidence of renal disease. The reason renal disease is so important is if I put a PICC line in the arm of somebody with CKD and they're going to need a fistula down the road, I may have caused them significant damage by ruining that arm as an access for a potential fistula site. So one thing I can know about that is if I can do that, I can avoid putting a PICC line in the arm and actually place something different. I've placed, I think, one of these here so far. I used to place hundreds of these. Are tunnel PICC lines. It's a simple PICC line that you've seen in the arm, but all it is I tunnel it in the chest the same way a dialysis catheter would go in, and they can get whatever medication the same way. It's the same size. It's really tiny. You can use it the same way on the floor. There's no problem with it, and it's actually reduces the risk of infection because it is tunneled. And it just goes right above the heart, the right atrium right here in the heart. And it preserves that vascular access site for potential fistula down the road. Or if they just can't get a PICC in the arm, that's one thing we can do. Tunneled HD catheters or tunneled infusion catheters, these are put in the same way. Those are just a little larger bore catheter. So this is just one thing I want you to keep in mind. If the patient can't get a PICC, this exists, and I can do that quickly, either under moderate sedation or even local sedation, so they don't even need to be NPO if it needs to be placed urgently.
Nima, can you comment on removing those tunnel PICC lines? Or nurses often can remove normal PICC lines.
Sure.
How does the PICC line removal go for a tunnel?
So for a tunnel one, these actually come out really easily if you kind of tug on it. And you really don't need to pull pressure on. I suture these in so they don't fall out. As opposed to an arm PICC, which has the stat lock, but this suture will hold it in place. But if you just cut the sutures and pull on it, if you hold pressure on the neck for about 30 seconds, it'll stop bleeding. And so if you're uncomfortable with it, I'm fine coming up to pull it. That's not a problem. But these can be removed at the bedside without any issue. Just holding pressure at the neck where the catheter goes into the internal jugular vein for about 30 seconds, it'll stop bleeding. Okay. Along that similar line, ports. So our surgeons do a great job of placing ports here. I have also placed ports, but the other thing I can potentially bring here is salvaging ports. So I don't know how many of you have come across this. I'm sure you have. You have a port that will flush but won't aspirate. It's not functional. I guess the standard we do here is place TPA and let it dwell for about 2 hours and see if it opens it up. What do you do if that doesn't work though? Do we replace the port? Do we put it on the other side? The problem with that is that's another procedure for the patient, additional cost for the patient. What I can do, and what I've done a lot of, and it's actually kind of fun, is I go up there. This is the standard picture right here where the catheter has a little bit of contrast pulling on the tip. That's an invisible sheath of scar that's formed on the catheter. And the TPA, if it doesn't break it up, I go up there with a little lasso through a small puncture in the groin. It's a 1.5 millimeter puncture. The lasso goes up, I grab the catheter, and I just rip that sheath off, and the catheter works great. That's all it does. It takes, how long it takes for me to lasso the catheter. And it saves the patient from having to trash that vascular access site. If they've had that port in for a long time, they don't have to place a port on the other side. Potentially kind of just ruining vascular access for patients is something I try to avoid. Preserving the vascular access they do have just makes life easier for them. So Other things I will mention briefly, dual lumen ports I've placed usually for lymphatic malignancies and also arm ports for patients with breast cancer or people who don't want scars on the chest. Arm ports are really useful for the mastectomy patients if they have a scar and you don't want to wait for port placement, or if they just want to preserve that cosmetic appearance of the other breast so they're not removing. This is a great option. They work really well, and they're fairly palpable. And if they have any issues in terms of learning how to access them, I'm happy to show you how to do it. You just basically grab it the same way with an arm port and access it, and it works just the same. Okay, on to the more interesting stuff. So angioplasty PAD, so this may be a patient you see in your clinic. The only thing she's missing, I guess, is her pack of cigarettes. But she's got the calf pain, the walking pain, it hurts. And of course, medical management is first line. You put them on the appropriate medication. You tell them to stop smoking. They don't stop smoking, but you try. So when should you consider sending them to some kind of potential endovascular therapy? So those patients who have persistent claudication despite medical management, or they're starting to show signs of progressive vascular disease. So they're starting to have rest pain, they're having tissue loss, or they have the acute cold extremity. Those are things that we can fix sooner rather than later, especially the cold extremity. Those are, in my mind, a medical emergency where I'll go in and try and open up the vessel right away. If possible, it is nice to have at least some ABIs or toe pressures or some kind of laboratory workup beforehand. But if not, again, those are things that I'm happy to take over if they show up in clinic. So brief introduction to how do we classify peripheral arterial disease. There's something called the Rutherford classification. The ones you're seeing in clinic, the mild claudicants, those are the 1, 2s, and 3s. Mild to severe claudicants, those ones that you're fine medically managing them, but maybe keep in the back of your mind, they might need peripheral intervention at some point. These ones down here, these 4, 5, 6s, the ones that have rest pain or they're starting to show signs of tissue loss, they might even need an amputation. Those are ones that I could potentially prevent the amputation, or if they do need to get an amputation, help aid that wound healing process after the surgery is completed. So I would go in, I'd angioplasty the vessel, they do the surgery for the amputation, and it promotes wound healing afterwards. What are the alternatives to doing endovascular therapy? So these people, they're sick. They have bad disease. Just because they have bad disease in the legs, it also means they also have bad disease elsewhere, usually the brain or heart. These patients get strokes. These patients have heart attacks. They die. 1-year outcomes in patients with critical limb ischemia, a quarter of them are dead. 30% of them will face amputation. With endovascular therapy, their 1-year patency rates and salvaging that limb, preventing them from amputation, gets as high as about 90%. It is a chronic process, and I'll probably will have to intervene on these patients, but we can at least keep them walking and keep them alive longer. And hopefully by keeping them ambulatory, we can reduce the morbidity and mortality from those other vascular events. Okay, pulmonary embolism. This is another one I sometimes consider an emergency. And actually here I've had quite a few, interestingly enough. So this is a CT scan. This arrow points to a clot in the pulmonary artery. And over here you see this right ventricle. That's showing the length of the right ventricle is a lot bigger than the left ventricle. It should be the other way around. So when we see this, this is indicative of right heart strain. So the way I classify, and a lot of people classify pulmonary embolism, is either stable, massive, or submassive. So the stable patients are the ones with just some clot. They're doing fine. They get heparinized, they go home on an anticoagulant, they do great. But it's this gray area between these massive and submassive pulmonary emboli. Massive PEs, all you have to remember is hypotension. If somebody has a pulmonary embolism and they're hypotensive, they need to be treated right away. And there's clear data and clear indications that they need to be treated immediately with catheter-directed therapy. You break up the clot, you open up the channels, you reduce that strain on the heart, you prevent that immediate mortality from that massive pulmonary embolism. It's this area of the submassive PE. So the patients who have right heart strain, they might have elevated troponins, they have elevated pressures on echo. What do we do with those? And there is some conflict in how to treat these patients amongst the different societies. The thing we do know is that these patients, regardless of how we treat them, do face significant mortality in that initial 30 days. So this is actually from a case I did 2 weeks ago here from a patient who had a massive pulmonary embolism. He had an episode of hypotension before he arrived at the hospital. He was a little more stable at the time, but given the presence of large clot on the CT scan and the presence of hypotension, we took him into the cath lab and actually sucked out a decent amount of clot from his pulmonary arteries. So that's the goal: is we go in there, we try and debulk the clot, open up the vessels and get over that acute, really dangerous phase of the pulmonary embolism. And then, of course, let the heparin take over, let the anticoagulant take over, and they do better. So again, here I kind of highlight the conflicting data data between the different societies. The American Heart Association, they say catheter-directed therapy can be indicated if they're progressing or they're not getting better on the standard medical management. The chest physicians still, I think at this point, recommend systemic therapy in those submassive patients. Again, hypotensive patients should be treated right away, okay? And I do appreciate the help of everybody involved in the care of these patients, ER, pulmonologists, cardiologists, all these people need to be involved in the care of these patients because that's how they do better. Along the same lines, IVC filters. So how many people here have seen somebody with an IVC filter? Yeah. How many people have seen somebody, those commercials at 3 a.m. saying, if your doctor's placing an IVC filter, sue the crap out of them? And it's because we put too many of them in. We really did. Like the United States puts far more filters in patients than any other developed country in the world, and probably inappropriately. So there are clear criteria on when they should be placed. There is again disagreement on when they should be placed, but the unanimous consensus on where to place a filter in a patient is somebody who has inability to anticoagulate, they've failed anticoagulation, or they're just unstable and you want to prevent them from getting worse. They have a clot, they have pulmonary embolism, you want to keep them from getting worse. Everybody agrees on those being placed. If they're sick, they're septic, you can place it does not matter. There are plenty of other indications to place them. The ones I also tend to agree on are patients with big mobile thrombus that are going up in the IVC. So if you see a big clot in the IVC, that could potentially become a saddle embolism. I think it's worthwhile to place a filter. I treat these as either urgent or emergent. I will come in to put this in. I will not wait till the next morning if I don't have to. I will try and come in aggressively to place these to prevent that from happening. I had one patient a few weeks ago. I was waiting to place the filter. I stayed late to place it. In the time when she was getting off the bed to come down to cath lab for the filter placement, the clot flew to the lung and she became very unstable. Luckily, we were able to resuscitate her, remove the clot. But that is why I think these are more of an urgent or emergent procedure to place. To prevent any kind of legal issues, I am very neurotic about following all of these patients. All of them are scheduled or called to come back in 3 months for potential removal if they can have them removed. I don't place those old green-filled filters or the ones that were permanent. We don't have them even in the hospital. Nobody should, because all filters now can either be permanent or removed. They all have that hook on there to remove the filter. And so this is actually, people often ask me what is my favorite procedure to do, and foreign body retrieval and filter retrieval might be my favorite thing to do because it is so fun. These are some videos of some filter retrievals. Usually the way these go, this is a really easy one. It's nice and straight. It's beautifully positioned. Probably not by me. Somebody else put it in great. But I go in there with a little lasso. I grab it. You come down with a sheath, and everybody kind of goes, "Oh, does he have it yet? Does he have it yet?" And there it goes, and it's out, and it's very satisfying. This one over here is a more complicated filter retrieval. Again, everybody's kind of watching you, kind of, is he going to get it or not? It's fun. It's like a video game, and this is with an endobronchial forceps. So these are endobronchial forceps that are from the OR. We borrow these. This hook is actually embedded in the cable wall, and I just kind of go in there with the hook and nudge it out of the wall and grasp it. And here you can see me getting close. I finally caught it. But the hook is sticking out to the side right there a little bit, and it's going to hit my sheath, and I curse a little bit, and I pull a little harder, and then it's lined up with the sheath, and it goes in the sheath. Slowly, come on, buddy, get it out. Hey, then it's gone. And these do really well. So even if you have somebody with a filter that you think it might need to come out, I will retrieve it. Even on ones that are more complicated, I will try and retrieve it. Okay, this is because I just enjoy it so darn much. And this is true for foreign body retrieval too. I'll retrieve anything that you've left in the patient. I'm happy to go in there. So moving along, venous thrombosis. So venous thrombosis was actually something I treated quite a bit in my training. I've yet to see any here for treatment, which is interesting to me because I think these patients do really well. The reason we may not be seeing them here is there is, again, an area of conflicting data and conflicting information on what to do for these patients. So it's a really common disease, but the sooner I see it and the sooner I can potentially treat it, the better they do. Once that clot gets older and more organized, I really can't do much. It becomes this big fibrin scar. I've removed some of those and they just don't do well. So the workup for the patients we see with DVT, ultrasound, right? These patients all get an ultrasound. They have that big swollen red leg. You get an ultrasound, we see a clot, done, right? Well, the problem with ultrasound is it only really goes up to about the inguinal region. We see the common femoral vein. We don't really see the iliac veins that well. And the reason that's important is if they have thrombus that involves the iliac veins or the IVC, those patients have a larger thrombus. And if they're younger and they're mobile, the problem is they develop this thing called post-thrombotic syndrome. And the larger the clot is, the more extensive the clot is, the more symptomatic they are, the more likely they are to develop that post-thrombotic syndrome where their leg is swollen, it's tender, it's usually a few months to a few years after that initial clot, and it really does affect their quality of life. They can't walk around that well. So there were 2 trials that kind of looked at catheter-directed therapy and DVT. The CAVENT trial, which was the first one that said, hey, we should do it, and the ATTRACT trial which said, hey, we shouldn't do it. So what do we do with that information? Well, you kind of look at both of them and you find a subset of patients who really do well. And that's the patients who are younger, mobile, active, and they have pretty symptomatic DVT that goes up to the iliacs or IVC. So if they have iliofemoral DVT, we should be treating these patients, I do believe. And I think this data between these 2 trials, even though one says not to do it, one says to do it all the time, between those 2 patients, we should be treating those patients to prevent that post-thrombotic syndrome, okay? So if you see a patient with a clot that goes up to the pelvis, maybe consider getting more imaging, or just give me a call and I may recommend getting more imaging, or I might say back off. There's no reason to here, but we can see if there's something we can potentially do for that patient to make their life better. And so this is a case, big bad clot. We went up in there with some wires, put a stent in there and broke the clot up. This is before, this is after. One subset of these patients I do want to bring to your attention is something called May-Thurner syndrome. These are the patients who are younger, who usually it's a young female. This is a classic story, who has a left leg clot and you don't have a reason why. It's because of anatomy. The iliac vein over here compresses the left common femoral vein over here, and because of that compression, they get clots and they need a stent. They need a stent. They will not get better. You'll get them on anticoagulation for life. And again, these are younger, healthier patients who want to be active. And if they're on anticoagulation, that really does affect their quality of life. If I can go in there and place a stent, that should reduce their the instance of DVT. And all they have to be on is a baby aspirin as opposed to warfarin or Eliquis or Xarelto, which are just really expensive. It's a $1 baby aspirin bottle a month. Okay, switching gears entirely, the role of oncology. What do we do in interventional radiology? So tumor embolization. So when I say tumor embolization, I showed this presentation to my sister last night, and she's a radiation oncologist. And she had no idea what the heck tumor embolization was. She said, oh, you just go up there and you blast it. And it's kind of true. We usually go up to the tumor with a small wire and catheter. We go directly to the vessel feeding the tumor, and we inject something in there to kill the tumor or stop the blood supply to the tumor. And the things that we have available, not here yet, but I'm working on it. One is radioembolization. So we put radiation particles directly in the tumor. Those sit inside the tumor, and they actually destroy the tumor. And this has great data. There's two devices out there. There's a resin sphere that's for colorectal liver mets, and there's a TheraSphere for a lot of other tumors. These both have FDA approval. I'm working on trying to get those brought to the hospital here because I do have great results. But we also do have something called Blandin chemoembolization. Same concept. We go up there with a little tiny wire, a little tiny catheter, and we inject either particles in there to stop the blood supply to the tumor, killing it, or we inject chemotherapy directly into the tumor. And the reason that's so good is it spares the normal liver itself from the chemotherapeutic effects or the radiation effects. These patients do really well in terms of survival. What we're doing here is, in this case, is trying to bridge that patient to transplant, resection, or just prolonging their survival, and we have great data for that. This also does include benign tumors, so the renal AMLs that are bleeding or symptomatic, patients with large hepatic hemangiomas or large spleens that are sequestering platelets. We can actually shrink those. Those patients do pretty darn well in terms of their platelet sequestration, and even in the splenomegaly patients, their encephalopathy does improve. So maybe that's coming here, maybe not, we'll see. I'm working on it. So hepatic malignancy, just quick thing about data, because I'm a data-driven person, and again, I could talk about this for forever. Just pointing out here that survival, there is level 1 evidence, and it's the standard of care for most, I think almost every single oncologic guidelines in using chemoembolization in hepatic malignancy, specifically HCC. We have great survival at 1 and 2 years respective to conservative therapy. We're there to help keep the patients alive longer and potentially get to that curative therapy of resection or transplantation. This is the algorithm they use in the Barcelona Clinic for liver cancer. That's where IR lives. If you see here ablation, where I burn the tumor, and I'll talk about that in a second, we can cure these patients with ablation. With chemoembolization, we can actually downstage them to the point where they can get curative treatment with ablation or resection or transplantation, or at the very least prolong their survival. So this is a case of chemoembolization that we've done. This is the tumor up here. I've gone up with a catheter and a wire, and I've stained it with something called Lipiodol. It's a fatty emulsion agent that has chemotherapy in it. The reason that's so nice is that I can do a CT scan and I can see the ball where the tumor is. There's the tumor right there. And then right afterwards, usually the day afterwards, we stick some needles in there and we use heat to burn the tumor, and this tumor is gone. It's destroyed. So this is a curative therapy for that tumor in the left hepatic lobe. And actually the heat itself we use here potentiates the effect of the chemotherapeutic agents. It's not going to prevent the other tumors from forming in the diseased liver, but it will cure that lesion. That's one thing I want to point out here. We can also do it for palliation. We can do it for benign or malignant lesions. This is usually an outpatient procedure. These patients go home the same day. I usually use general anesthesia, not because they have to, but because I think it's a little easier to do it. Surgery is still the gold standard. I'm not trying to say we should not perform surgery on these patients, but this is an alternative for the patients who cannot get surgery. And we get curative control. The best results are usually lesions that are 2 to 3 centimeters in size, but we have done ablations, curative ablations on tumors that are 7 centimeters in size, so quite large tumors. And we have done oligometastatic disease, so if they have a small number of lesions and they're symptomatic, we can ablate those lesions and they do darn well. I use both heat and ice ball, so there's different modalities. Microwave ablation is the heating ablation. It's the same microwave you use to warm your bread. A little different modality of delivering. I don't put them in the microwave. I put probes in there and I microwave the tumor. And also cryoablation. This is actually an example of cryoablation where we have an ice ball that forms along the tip of the needle and it destroys the tumor. We get excellent results, 90 to 100% cure rate at 1 year, around 70 to 80% at 5 years. Okay, along the same vein, but now moving out of the oncology world, we move to uterine artery embolization. So what is uterine artery embolization? Same thing, I go down with a wire and a catheter. Some people go through the groin. I actually like to go through the wrist. So if you know patients who had cardiac catheterization before, instead of using the right wrist, I use the left wrist. I go all the way down to the pelvis, into the uterine artery. And if the patient has fibroids or a reason for me to embolize the artery, I inject tiny little particles. So is it little beads or just little gel foam pledgets to kind of stop the blood supply to the pelvis. And the way this works is that it actually shrinks the fibroids in the pelvis. And so the patients who are having symptoms of abnormal bleeding or cramping or just that fullness sensation they have from large fibroids, these fibroids shrink, and they shrink, well, pretty rapidly in a few months. And again, the technical success rate on this is about 90 to 100%. This is an outpatient procedure. I typically keep them overnight just to give them some pain control, but about half of the patients I do this on just want to go home, and I send them home the same day with some pain medication. I would ask to get an MRI beforehand just to make sure there's nothing else going on. If they have, instead of a fibroid, they have a tumor or they have adenomyosis, a different thing that can cause pelvic pain, but also to help me see how effective this is going to be, because it is effective for a large number of patients, but every now and then, like this one here, there's a chance that this might break off if I did an embolization on this one. So I tend to say, send them to surgery. And surgery, again, is the gold standard for treating these patients. That's going to remove the fibroid, but these patients do really well, and they're actually quite happy. We actually measure satisfaction with these patients, and greater than 90% of the patients are very happy with this procedure done in terms of resolving their symptoms. One side note is, if you have a patient who's bleeding after pelvic surgery, this can be done as well. So if you have a cesarean with prolonged postoperative bleeding, we would often go in and embolize this and reduce their bleeding risk. Or if they have a patient who has a presumed bleeding risk preoperatively, we would often go in, embolize the uterine artery, and then they would immediately go to surgery, and they would have reduced bleeding during the surgery and require less blood products. So this is the procedure. This is the abnormal tangle of vessels down here supplying the fibroid. We go in with a catheter, we embolize it. You no longer see those vessels. This is pre-procedure. There's the fibroid. That's the fibroid shrunken down and necrotic. It's gone. There is a low risk of infertility for this procedure, but it is lower risk than removing the uterus entirely. So that's what I generally say. And that risk is greatest usually in women greater than 45 years old. So, and again, if they're wanting fertility there, send them for myomectomy, but it is pretty darn low, and it does save them from having a surgical procedure done if they don't want that done. Same vein, gonadal vein embolization. So patients who have scrotal varices or they have pelvic congestion syndrome. This applies to both men and women. So men get varices, they have scrotal pain, they have some issues with fertility, or they have a woman who's got postcoital pain or tenderness down in her pelvis over the area of her ovaries. They sometimes have this condition where their gonadal veins become big and engorged. We would go down there with a catheter and drop a bunch of coils in there, and this varix will resolve. It'll just absorb and go away. We often do these if patients failed surgery or they did not want surgery. Our success rates for both are about 90%. So again, quite good. And I think that varies on how many coils you like to deploy, and I like to push a lot of coils, so they do a lot better. It probably costs a lot more money, I apologize, but it works great. Switching gears entirely, away from the pelvis, we go to dialysis. So this picture right here, does anybody know what that is? It is the first dialysis machine ever made. It was made from a washing machine and tin cans and sausage skins. Shockingly, the first 15 patients died. But the 16th lived. She did great, actually. So she woke up. This was in Holland in like 1943, so World War II Holland. They did dialysis on this patient with acute uremia. They ran dialysis for hours, and very slow, I think by actual hand crank. And when she woke up from her uremic coma, she said, "I'm going to divorce my husband," and she did. And she lived for a few years, happily divorced, so good for her. We're a little better now. Our survival rates are a lot better with dialysis. This video is going to go really fast, but this is about how quickly fistulograms go for intervening. Just ignore the 1 hour sedation time at the end at the top. But this is me ballooning a fistula to make it work again. So our interventions for these kinds of patients, we can get them back to dialysis very quickly. A fistulogram usually takes about 30 minutes or so to get them back to dialysis, so we can get their dialysis access working again if you come across a patient who has prolonged bleeding, their arm swelling, or just slow flow on the dialysis machine. A new thing that has actually just come out, it was approved last November, and CMS just started paying for it in January, and I think the first procedures in the United States were done in March, is endovascular fistula creation. Basically what we do is we go into the arm with these two small catheters. They have very strong magnets on the end of them. You advance them towards each other and then turn them and they attach. One is in the artery, one is the vein. We fire a little radiofrequency fire to burn a hole between the two, and then they have a fistula. It matures the same time as a surgical fistula. It has a better maturation rate than a surgical fistula. It has a lower reintervention rate than a surgical fistula. It has a lower cost than a surgical fistula. I honestly believe that in a few years, I'm not being paid by these guys, I promise, but I really do think that this is probably the future of fistula creation in America, just because of how well it does. We'll see how the data goes. It's still early on, but if this is something we could do here as well. Biliary interventions. So this is for the GI folks. So patients go to ERCP, they have a stone, they have some blockage, or they have cancer, they have a blockage, they go to ERCP, that's the first line. But if for whatever reason that doesn't work, or they have a prior gastric bypass and we can't get to the bile ducts, that's where we come in. I go percutaneously through the skin directly into the bile ducts to treat those patients. So these are the patients that are sick. They have acute cholangitis, they have a bile obstruction, they have a bile leak, or I can even go in and recanalize a stent that's blocked off just through the skin by sticking through the skin into the bile duct directly. I generally do these under general anesthesia because they really hurt. I've done this once on a patient under moderate sedation. I will never do that again. They scream and hit, and it's not fun for anybody, particularly me. And they can be quite ill as well too. So general anesthesia's assistance is always very appreciated in maintaining these patients' stability. So this is how the procedure goes. This is what, if you look at this tangle of whatever this is, those are the dilated bile ducts. We're in there, we're injecting dye. We can see how big and dilated they are. We place a catheter across it, and this is actually into the bowel. Every single one of these I place, so they're gonna leave with a tube sticking out of the side, and nobody likes that, but every single one of these I place, and this is true for biliary as well as nephrostomy catheters, I put in with the goal of internalizing them so they don't have to walk around with a bag, because that stinks. Nobody likes that, and it's a mess, and the nurses don't like it because you have to empty it. If we can internalize these patients, their quality of life is much better. So I place all of these with the goal of ultimately, if I can, placing a stent inside them so they can go home without a tube sticking out of their side. One thing I will mention too, so we have pretty good results for managing benign biliary strictures after surgery. I serially upsize these tubes until it dilates the tract over about 6 to 9 months, and they go home eventually without a tube at all. All right, gastrostomy, GJ tube. So We place gastrostomy tubes as well. Most people don't realize that. Of course, the surgeons, the endoscopists, those guys do a great job, but I do this under fluoroscopy, where I actually puncture the stomach under fluoroscopic guidance. And traditionally in patients who couldn't get endoscopy, again, we can place G tubes in the hospital and they can go home. It's an outpatient procedure done under moderate sedation. Or if they even have a G tube in place that's not working, I can change it. Or if they have a G tube and they're aspirating, I can actually put a GJ tube in. So if they need feeding further down the road, if you're noticing a patient that has a gastrostomy tube that it keeps refluxing, I can convert it further down the road, post-pyloric, so they don't aspirate. So this is something we do in fluoroscopy. Again, outpatient procedure, sometimes done even with local anesthesia as well. If it's a surgically placed G tube, I can just put a tube through it and make it a gastrojejunostomy tube, again, saving the patient from potential morbidity and mortality from their dysfunctional G tube. PleurX catheter placements. How many of you have seen a PleurX catheter or know what a PleurX catheter is? Nobody? Very few. Okay, so a PleurX catheter is a catheter that stays inside the patient who has malignant effusion or malignant ascites. They have to keep coming back for taps again and again and again, and that's really inconvenient and uncomfortable for the patient. They have to get stuck over and over again. It's significant cost. And if you know you have a patient who has recurrent ascites, recurrent effusion, we place this catheter. It's an indwelling catheter, much like a hemodialysis catheter in appearance, with a cuff that goes into the fluid, and the patient at home will be sent these bottles to drain themselves. And it's very safe. There's a very low infection rate. They don't have to come to the hospital. These patients have cancer. They don't want to be at the hospital. It stinks for them. If they can be at home with their family, or they can be at hospice, or they can be somewhere else besides here and make their life more comfortable, this is a great alternative for those patients. So if you're seeing in your clinic a patient with this situation, it's really something to consider, because even in those pleural effusion cases, just by placing the catheter, that irritation alone, half those patients that are pleural effusions will just go away spontaneously. Okay, the most exciting procedure in interventional radiology is the TIPS procedure. So a TIPS procedure, that stands for transjugular intrahepatic portosystemic shunt creation. And that's exactly what it sounds like. Nobody knows. I just said a lot of words. So what it is, I go in through the neck into the liver with a very long, very sharp, terrifying needle, and we stab through the liver into the portal vein to create a shunt. And it's actually a great procedure because this is one of the few emergent procedures that saves somebody's life. So you have a patient who has refractory variceal bleeding. They go to endoscopy. They have huge varices. They can't control them. They're usually having massive hematemesis. They come to the IR suite. We create the shunt emergently. And I'm sweating a little bit during this case. But we get it in there and they do well. It actually decompresses that congestion they have from the liver disease. Their varices go down. I'll actually go in there sometimes and even embolize the varices as well to stop that bleeding more acutely. And they do quite well. So that's one of the indications. The other one is, again, that patient who has refractory, not malignant ascites, but cirrhotic ascites. So patients who don't have malignant ascites, but they have ascites from the liver disease, I can go in there, create the shunt, and decompress that pressure that causes that fluid buildup in their abdomen, and that they do great. One thing I want to point out, this is kind of a bit of a trivia. Do people know what the MELD score is? Or has anybody seen it before? It's a scoring system we use for liver disease. It was actually invented by interventional radiologists for this procedure. It was not invented for liver disease. It was invented to tell us when are we going to kill this guy by doing this procedure. And so I use a score to tell me if I should or should not do it. Around a MELD score of 18, I'll say maybe not. And this is how the procedure goes. That's that large needle. I stab a bunch of times. I get in and I put a stent in there. So if you see a patient who has one of these shunts in there and they have recurrent symptoms like they're bleeding again or their ascites is coming back, or you get an ultrasound that says it's not working that great, I can actually go in there and repair it. Or even if it's too large and the patient becomes encephalopathic and too much blood is going past the liver, I can shrink it back down. So both of those things do exist. I can manage these. It's quite fun. A more safe version of the procedure that doesn't go all the way to the portal vein is a transjugular liver biopsy. So how many people have ever seen a liver biopsy done through the neck or knew that was a possibility? Yeah. So this is something that's actually safer than the standard way of doing a liver biopsy. It sounds crazy, but it really is. It has a lower bleeding risk because we don't actually penetrate the capsule of the liver. We don't go through the skin, so they don't bleed into their abdomen. They bleed into the liver parenchyma, and that just stops it on its own. So we often do these on patients who were not candidates for percutaneous biopsy. They said, oh, they're going to bleed. Their INR is too high. They don't have enough platelets. These people have liver disease. They're going to bleed. So we can't just not do the biopsy and not stage their fibrosis and treat them. So we would do this through the neck, with a catheter, a long needle, do the biopsy. It's quick. I do these in about 15 to 20 minutes. It's outpatient. They go home. And like I said, the risk of bleeding is much, much less than through the percutaneous route. Still, I think most people prefer it because the idea of a patient hearing that you're going to have a giant needle in their neck sounds kind of scary, but I really promise it's safer. Brief note, sclerotherapy. So this is probably for the surgeons or patients who have had surgery. Postoperative seromas are common, particularly in the mastectomy world or any large tissue flap world. Basically, these patients get fluid buildup in their surgical site. You drain it, it comes back. You drain it, it comes back. It's terrible. It's really uncomfortable for the patient. And so what we do is I go in there with a catheter. I inject a sclerosant, which is either an antibiotic that actually causes scarring, or ethanol, or another material in there to kind of cause scarring of that pocket where that fluid keeps building up. And that pocket scars on itself and doesn't refill. So those patients who have repeated seromas, repeated fluid buildup in those areas, we can shrink those down and prevent them from coming back. That actually also applies to patients who have symptomatic renal or hepatic cysts. I also do this on patients who have slow flow vascular malformations on the skin. So if you have, it's usually a younger patient who has this big bulbous venous collection that we usually get an MRI and identify. I go in there with alcohol under general anesthesia and inject alcohol in there, and it actually collapses the vessels instantaneously and they don't grow back. It usually requires one or more treatments, at least two on most of the larger lesions, but they do really well, and it saves them from having to come back again and again and again. And it really makes their life, I think, a lot better from having to deal with that postoperative seroma. Adrenal venous sampling. Okay. I don't think this has been, I don't know many people who do this, but the place I came from, we did a lot of this. And there's actually not many places that do a lot of this, and it's actually quite shocking. So an adrenal adenoma is something we commonly see in imaging, are commonly sent to us in the radiology world and the diagnostic world to identify an adenoma. What an adenoma is, it's a nodule in the adrenal gland that could potentially be hyperfunctioning. And these patients have hyperaldosteronism or they have hypertension. And so the idea is you find the nodule and you cut it out, right? That is actually the wrong way to manage these patients, because half the time, the one that you see is not the one that's malfunctioning. And so you could potentially remove the adrenal gland that is normally functioning. It just happens to have an appearance of an adenoma, but it's the microadenoma on the other side that's causing the patient's symptoms. And you don't know that by imaging. And if you remove the wrong one, they cannot have surgery because you can't remove both adrenal glands. So we would do this preoperatively to identify. We would actually go into the adrenal gland itself, into the vein with a tiny catheter, take out some blood, and we'd compare the ratios of the aldosterone in each adrenal gland and say, that's the one that's abnormally functioning. That sends the patient to the right surgery because, like I said, if you remove the wrong one, or if you remove an adrenal gland based on imaging alone, almost half the time you're going to remove the wrong one. So. Renal artery stenting. So this was a hot topic a few years ago because everybody was stenting the renal artery. We'd fly by, we'd say, oh, that looks a little small, and we put a stent in there and just bill. And it was wildly inappropriate. There have been plenty of studies that have reviewed this and say, no, you should not do this. And I completely agree. The Coral was the largest one. There's been lots of meta-analyses. We stented the renal artery way too much, and patients had complications for it. So I don't think we should stent it all the time. There are, again, still certain instances when the renal artery you should consider endovascular intervention. Those patients who are failing despite optimal medical management, because that's what they should have, is optimal medical management. The patients who have flash pulmonary edema are the ones who are having decreasing renal function despite optimal medical management. So their blood flow is not going, there's not enough blood flow to the kidney's shrinking, they're kind of going down that chronic kidney disease route. At that point, maybe consider it. I'm not pushing for it, but I'm saying it's something you should still keep in the back of your mind. The last patient who should have endovascular therapy and they don't do well with medical management are patients with FMD, which stands for fibromuscular dysplasia. And that's what this looks like. It's this kind of beaded, funny appearance where basically the vessel wall grows abnormally. And it's, again, same concept. It slows blood flow to the kidney and causes symptoms of renal disease and hypertension. Those patients do really well with angioplasty alone. I go in there with a balloon, I dilate the vessel, they do great. So if you see a younger patient with resistant hypertension, keep this in the back of your mind. And if you get a CT scan and identify it, that's something we can treat endovascularly. Emergencies. So I really enjoy emergencies. There's a lot here. I've talked about some of those already. So the patients who have traumas, those are really fun. And we can save the patient from having a splenectomy or a partial hepatectomy or big invasive surgery that can go very badly. I, again, go in there with a little catheter. I selectively embolize the bleed, and I save the rest of the normal tissue. They don't have to have their liver resected. They don't have to have their spleen resected. They don't have to have their bowel resected. We go in there, we stop that one tiny little bleeding vessel and save them from an operation entirely. They don't even have to go back to the ICU. They can go back to the floor once the bleeding is stopped. Often they still go just because we're worried about them, but we've had surgeons who say, no, they're fine, they're done, the bleeding is controlled, and they go home. And that really does reduce their hospital stay. Patients who have massive hemoptysis, usually it's the CF patients or patients with chronic lung disease, we would go in there and save them from their massive hemoptysis endovascularly, because bronchoscopy doesn't really work in those patients. And so you go in there, you bronch them, you can't find whatever's bleeding, we can with our little tiny catheters, and we inject stuff in there, and they do great. They will reoccur, but we can at least save them in that acute stage. I've already talked about biliary nephrostomies, PEs, and venous thromboembolism. Again, though, these are all things I would consider emergencies, and please do not hesitate to call me. I will come in, even if I'm not on call, at least call me and let me know I'm available. New frontiers. IR is a very innovative specialty. That's why I like it so much. 20 years ago, we were just stabbing people with a needle and injecting stuff and walking away. Maybe a little longer than that, but we've really innovated a lot in the last few years, and every year it seems like a new thing is coming out. We can do prostate artery embolization for BPH. We can treat hemorrhoids. We can actually do gastric artery embolization for weight loss. So as an alternative to bariatric surgery, there's a bunch of IR guys out in Maryland who are doing this procedure where they go in through the wrist, down to the artery supplying the stomach. They embolize it, and that's it. And the patient has weight loss. They don't have to have a big bariatric surgery. They don't have to have a gastric sleeve. Again, there's debate. I think the bariatric surgeons are not really in favor of this. But these are just an example of, and I'm not trying to advocate for one thing. I'm just saying these are things that we're working on in interventional radiology as new and improved things. So even if you've heard of something I haven't heard of, let me know. I'm fascinated to hear about it, and potentially it would be something we could bring to our patients here. Okay, so I've rambled enough. Hopefully I didn't talk too quickly. Hopefully I didn't confuse anybody. Does anybody have any questions? Yes?
For the patient with diagnosed pulmonary embolism, which patients would you recommend we go further testing for the legs to see if we can prevent them?
That's a great question. So patients with PEs, and the question was about patients with pulmonary embolism and when should we look to see if there's anything else. Honestly, if the patient is in that kind of tenuous phase, or even if you look down and you see they have a big swollen leg, it's helpful to know, because that one patient that kind of did decompensate, she was the one who had pulmonary embolism, and she had a big clot in her leg. And I was going to put a filter in to prevent exactly what happened to her. So clinically, if you think they have a clot in their leg, it could be the bigger one, the one that's causing the small PEs, could be those small sentinel clots that are flying up. There could be a larger one that's in their leg that we need to prevent in that acute setting. So that's one I would consider placing one in. Or again, those patients who are a little more unstable, the ones that are showing, they're a little short of breath, but a little more than just short of breath. Maybe they had a syncopal episode, or maybe they were feeling kind of dizzy or lightheaded. I honestly think it's worthwhile to make sure they don't have a big clot burden in the leg that's going to fly up and add to that and make their clinical situation much worse, because I've seen it happen. Thank you. Yes. One.
So you mentioned the value of this in a renal sampling. You said it's really important. I know you think
Hyperaldosteronism, or the adrenal hyperparathyroidism? Oh, for adrenal venous sampling?
so you mentioned that you can use it for adrenal venous sampling.
Yes.
Use it for parathyroid venous sampling.
I don't know. I've never heard of that, but that's one of those things that maybe exists.
Times that you have to do venous sampling.
Okay. Yeah, I mean, this is one thing that could be an area that I could look into. I mean, it's the same concept of getting a catheter into a very small vein. And if that's something that's being performed, I would happily look into it as a potential, thing to bring to this area. That's good to know. Yeah. Yes. Neurointervention. That's the ophthalmologist up there, correct? Yeah. Everybody's always, so So where I trained, we had neurointerventional radiologists and interventional radiologists. My cutoff is the carotid. I'll treat carotids. I don't go higher because I don't want to hurt anybody my first year out of training. So I generally leave those to the neurointerventionists or people who have trained in that as well too. Okay, great question. Any other questions? Okay, I think I'm done. Thank you.